Okay, well, I'll start. The first thing to say, really, is that I'll be talking about angiomyolipomas, or AMLs, is how I'm going to say them, along with LAM. And the talk's one that is given I give with Ian McCafferty, who's the interventional radiologist who I work with very closely. So it's certainly a joint talk. And I have to thank him for a lot of the slides he's given me, especially on the radiological aspects. So what I'm going to go through, well, what is an AML? How common is it? What causes it? What's the natural history? How often does it grow? How often does it cause problems? And when it does cause problems, well, what are the signs and symptoms? And how often, and how does it tend to present? I'll also be talking about, well, what interventions are available, and should we be intervening? And if we do, when should we be intervening? We've devised a protocol as a rough guide to how to manage these AMLs, and in particular the follow-ups. But this is not cast in stone by any means. And a little touch on some of the future aspects and opportunities. So what is an AML? Well, if you look, let's have a look. Can you see the pointer? Yep. So this is essentially a benign tumour within the kidney composed of three elements. Angio, i.e. blood vessels, and you can see the nice blood vessels forming there and there. Myo, which is smooth muscle, so not skeletal muscle, but smooth muscle. And fat, shows up beautifully. And what does it look like on scans? Well, let's take this one. So you've got an AML there, and it's glowing, mainly because it's an angio-rich one. So that's a small one. But then you've got this other extreme here. So this is the kidney. This is a CT scan. That's a little liver edge. And you can see this huge AML. And this is what they tend to look like. So this is the kidney from a specimen that's come out. And this is the AML. So they can be quite dramatic indeed. How common are they? Well, you've got some really old series here. So you've got 1969. This is an autopsy series which calculated in men accounting for about 0.02%, and in women almost 10 times higher at 0.29%. Another way to look at it is to do a population-based study, and this is one from Japan that I've put up here from 1995, and they based it, men, the AML rate to be 0.1%, and in women 0.2%. So low figures, and if you look at the world, so if we say the world population is 6 billion, what you'd work out to really is that there are probably about 10 million people out there with AMLs, and 1 million people with tuberous sclerosis complex, and we've got a couple of slides on that later on, associated AMLs. So not massive numbers, but not an insignificant population. What causes it? We don't know what causes it, but we do know there are some risk factors or associations. And these are the first two ones affecting other organ systems. So you have tuberous sclerosis complex and LAM. The third risk factor is being a woman. So what you've got here is that about 86% of women, so if you look at all the studies and you look at them really, so in overall 86% of women, it presents 80% of women. As far as LAM is concerned, what do we know about AMLs in LAM? Well, in sporadic LAM, you've got about a 50% chance of having an angiomyolipoma. In sporadic LAM, if there is an AML, it's usually single, it's usually on one side, i.e. affecting one kidney, it's often small, and it's often restricted to the kidney, so the bottom left picture as opposed to the top right picture, which was really prodding out. Whereas things are different in TSC LAM. These ladies tend to have AMLs which well, they're much more common, so almost 80% of ladies with this will have an AML of some description. They're often bilateral, they're much larger, and they tend to bulge out of the kidney more often. And they also have a higher chance of causing trouble, so i.e. bleeding, hemorrhage. How do they present? AMLs, by their very nature, are often silent. And so it could be an incidental finding on routine scanning for, say, the lungs or something else, especially the smaller ones. There is supposed to be a classic triad, and my next slide has got it, of flank pain, a tender palpable mass, and blood in the urine. That's hematuria, blood in the urine. And that's not uncommon. Almost 60% present with this, but that's usually a very big AML. It has to be quite big before you can start feeling it. Could also present just on routine testing, so non-visible hematuria, i.e. when your GP or you go to the hospital and you've had your blood checked, you had your urine checked with a dipstick. And then there are some uncommon ones which are essentially a sign that it's really big. So if it's really big and it's starting to press on certain aspects around the body, then it can have mass effect. So the renal insufficiency, i.e. the kidney's not working that well, could be because it's got so big that it's pressing on normal kidney tissue and stopping it from working, i.e. a late sign. And same again for UTI, urinary tract infections, or anemia, because it's got so big that you might be losing blood into it. Or the UTIs, it's causing a blockage to the drainage of the kidney, and so just like a static pool pond in your garden, you get bugs growing in it, and that's what the cause of a UTI is in this group. So how does it present? Well, what you've got here is, this is the Lex triad, this is the pain, the mass that you feel, and the blood in the urine. And it occurs in about 60% of patients presenting. What do we know about what's going to happen? So if there's an AML, well, what's going to happen to it? The problem is lots of the data is quite old, and it's also on not enormous numbers of patients or people. So it can all be criticised. But having said that, this is the best of what we've got, and we've got to make the most of it. So the first thing to say is that compared to sporadic AMLs, tuberous sclerosis-related AMLs present in a younger age group, are larger, are often multiple, and more commonly present with bleeding. So here's symptomatic acute hemorrhage at 44%. Tumour on average at 9 centimetres almost compared to 5, so almost double. And you've got the age range difference as well. Can we get a handle on the growth characteristics? Well, first off, only 35 patients. Okay, but a 4-year follow-up. And what we've got here is, let's look at this graph first. So this is the number of tumours that grow. And in the light blue is the patients with tuberous sclerosis, and in the dark blue are sporadic AMLs. And what we can tell, right from this graph, is that if you've got a TSC AML, it's much more likely to grow. And not only is it much more likely to grow, it's also much more likely to require some kind of intervention. And we'll talk about the intervention in a few slides from now. But in only 4 years, half of these patients with TSC AMLs required some, or had rather, let me put it that way, had some form of surgical intervention. And you're starting to get, I've got some slides on this later on, but you're starting to get a little bit of risk stratification here. So if this is split up between, now this, the light blue is not TSC and the light dark blue is sporadic. Now we're talking about size. So if we look at the light blue here is less than 4 centimeters, i.e. the AML being less than 4 centimeters on CT definition, or being more than 4 centimeters, you can see that if they're already big, they're more likely to grow. And if they're small, they're less likely to grow. It's a bit like the prostate, that, actually. Okay. Now, this is, for us, one of the landmark papers. So 253 patients. 20% of these patients had TSC AML. And they were re-stratified into those tumours that are less than 4 centimetres and those that are more than 4 centimetres. Now, you can see in the percentages I've put that represented less than 4 centimetres, a third of patients, and the majority were more than 4 centimetres. So there's already a bias there that in this group of patients they already had much larger AMLs. But essentially, let's look at this line. So we've got, in the smaller tumour size, the percentage that was symptomatic were 23%. Whereas once you've gone over 4 centimetres, then 82% were symptomatic. So you're starting to get a handle on what causes, when do they cause problems, i.e. 4 centimetres, according to this study. And this is borne out by quite a lot of others as well. So that's the one we've had a look at. But essentially, less than 4 centimetres, this is symptomatic at presentation, and you can see, generally speaking, low figures, but much higher when the AML is bigger. So the bigger it is, the more likely it's to be symptomatic. This is looking at what intervention they required and splitting it up. What you can see here is less than 4 centimetres and more than 4 centimetres, and you've got 43% of patients in this study required some form of intervention, be it an embolization, be it what's partial nephrectomy, that is removal of the AML but leaving the kidney behind to try to spare renal function, or removing everything, the tumour and the kidney. And what you can see, so less than 4 centimetres, about 43% required intervention. But when there are more than 4 centimetres, almost all of them required or had some form of intervention. I want to point this out to you here. This is not a good sign. In this group, 82%, when they had an intervention, had the tumour and the kidney removed. I leave it too late, and in this group what's happened is that they've lost the tumour plus the AML. And I mean, that was just one study, but this has really been backed up by other studies, a lot of number of other studies there, and essentially less than 4 centimetres, more than 4 centimetres, and there's a really big discrepancy between those that require intervention. So summarising what we know about the natural history of AMLs, so the risk factors are an association with tuberous sclerosis complex and size. We know that 82% of AMLs that are more than 4 centimetres are symptomatic. We know that 23% of AMLs that are less than 4 centimetres are symptomatic. And that more than 50% of AMLs that are more than 4 centimetres will bleed. And overall, a third of patients that present in the studies presented in quite extremis. And the problem with presenting in extremis is you can't do fancy things like embolizations. What you're really down to is intervening with life-threatening interventions, i.e. the kidney comes out. Okay, no keyhole surgeries there. And therefore, the major risk from all these series is is bleeding, retroperitoneal hemorrhage, RPF. And you've got one here, that's where it's bled from, and this is all blood clot there. And more on this side. So what about intervening? Well, there are a number of steps you can intervene at. You can intervene when they're symptomatic, or worse still, when they're actually actively bleeding. Or we can intervene when patients are asymptomatic. The problem is we've got no trial evidence about what the right thing to do is and whether what we're doing is correct or not. So what can we do? Well, there's lots of things that we can do. Well, firstly, we could biopsy the lesion. We don't do that often because the vast majority of AMLs are benign lesions. We have done it when it's not looked completely normal. And then when there's a diagnostic uncertainty, we have certainly biopsied. That needs to be by a specialist because you're biopsying essentially a bag of blood and fat. So you can cause some bleeding. Nephrectomy, so we could remove the kidney itself with the AML. But we really, I think in 2013 and going forwards, we shouldn't really be doing this. We've left it too late. You might want to do it if we know that the kidney's not working anyway. And you might get more AMLs in that kidney. So removing it, that's a small caveat. I think what we're really looking at is what's called nephron-sparing approach. Now, I deal with cancers, cancers only, and it's the expertise that I built up in cancer surgery, taking the tumour away and leaving the kidney behind, that's now I've transferred to this benign work, the AML work. But this, for the last 10 years, has been standard of practice in cancer surgery. If we can remove the tumour, leaving the kidney behind, that's what we should be doing. Okay, and we should be doing that not because we know for a cancer point of view, and this is not a cancer, remember, but from a cancer point of view, the cure rates are the same. But more importantly, what the studies have now shown is that those patients where you've left the kidney behind, as opposed to those patients that you've removed the tumour and the kidney, are much more less likely to run into problems with kidney failure in the future and death from kidney failure or from blood pressure issues. The more kidney you can leave behind, the less problems you're going to get in the future. And I can't see why that doesn't really transfer to this situation as well. So the interventions are partial nephrectomy, where you remove the tumour and leave the kidney behind, and that could be done open or keyhole or robotic. These are experimental is the wrong word. I think we'd have to be cautious with keyhole surgery in this at the moment until the experience is built up. You can freeze it. Not many people are doing that. And the next most important is embolization. Well, why embolization? Because the tumour is made out of 3 parts: blood, fat, and smooth muscle. But it's the abnormal blood vessels, because the blood vessels are abnormal because they're not supported by the tissue around them as they are in normal tissue, so they're more likely to bleed. And it's that bleeding risk which is the big risk, as I've pointed out, and therefore blocking the blood vessels is probably the right way to intervene. Well, why the QE? Well, I think this is a very uncommon tumour. And so the way not to go about it is that each radiologist, each surgeon around the country does one in their lifetime. Okay, we're really not going to get any further forwards as far as quality of the service we provide, as far as learning something and improving the intervention in the future, and as far as doing any studies to get some facts into this. Now, so what's important is that it's centralised. Now, you will be the 3rd patient group that I work with quite closely. Because I deal with genetic kidney cancers, I work very closely with the von Hippel-Lindau, which is a genetic tumour group of patients, and I talk to them a couple of times a year. Bladder cancer, again, there's this, I'm president of the Birmingham, the West Midlands rather, support group. So I know what's going on with the kind of rare kind of tumours. And what we at the QE, certainly, we've got the expertise to deal with these, both intervention and surgically. I think I'm going to add one caveat here, or one addition here, is that this is slightly different from the other patient groups that I deal with, in that, so let's talk about the genetic kidney cancers. The group is based in Birmingham. The national group is based in Birmingham, and so we see these patients. I see the patients a couple of times a year. So the sort of camaraderie builds up. With LAM, you're based in Nottingham, but you travel from around the country, and I think it's unfair that you'll be seen regularly in Nottingham, possibly in your local hospital, and then also in Birmingham. So in a way, we're at a bit of a disadvantage in that we provide high-end intervention, but you will miss out, I have to say, you will miss out on the sort of the camaraderie, because you'll essentially come to a massive new hospital. You saw the pictures on the first slide. You'll have the intervention. We'll make sure you're okay, but then your follow-up to save you, time and effort will be at Nottingham or at your local hospital. So, it's not something that you'll see. I'm more than happy if you want to come down to keep seeing me again, that's fine, but that's not the way we've set it out. So you might feel a bit of a difference there compared to, the excellent atmosphere that's built up here. So what about embolizations? Okay, this is a QE experience. Over 4 years, we've done quite a number, 65, or not, Ian's done quite a number, 65, 9 of them for AMLs. And that's gone up. It gets up more and more every year. What do we know? We know, generally speaking, I've shown you this before, that as the tumour increases in size, the chance of it, the chance of it rupturing increases as well. Now, what actually happens is you've got abnormal blood vessels, and sometimes, because they're abnormal, they get a little outpouching, what's called an aneurysm. And it's the aneurysm which is the most weakened bit of the blood vessel, and that's the bit that ruptures. And we know that when the aneurysm is about 5 millimeters in diameter, that's when the risk of it rupturing increases. So the current guidelines for intervention are a size criterion, and that's the AML being over 4 centimeters, aneurysm being more than 5 millimeters. And what we should be doing, as I've said, is to try to treat the tumour and not the kidney, and leave the kidney behind. So I'm only going to put one slide on the surgical intervention, because the majority really is radiological. But this is the surgical slide. So this is the kidney. This is an open operation, patients on the side, and what we've got here is, this is a sloop that's around the ureter, and that's a sloop that's around the blood vessel going in, the artery, so that so I can control it. And what happens here is that then I put a bag around it, and then there's cold ice put around it to cool the kidney down, and then I block off the blood supply to the kidney, and then you essentially cut around the tumour, leaving the normal kidney behind and taking away the AML, and then you sew it up again. Take out the ice, let go of the clamp, bingo, done. What you've got here is an essentially healthy kidney here. Yeah, you've got to do a few to get it right. We know that we can embolize the tumour rather than surgically intervene, but it's not without, and we've known this for quite a while, but you get recurrence of the AMLs in up to 1/3. So it's not a panacea, and you might need it again. This is a UK experience. Now, embolization can be done electively, i.e. when it's asymptomatic, or acute, i.e. in the heat of battle, when the patient's symptomatic, or when the bleeding's already done. And what I've said about, this really reinforces what I've said before about if you can do it electively, it's much better. Because this is, if you look at here, this is the rupture rate once they're having an embolization. And this is elective embolization, and the total rupture rate is 23%. This is in Leeds. A modern series in 2008. But when a radiologist is doing it because the patient's exsanguating, the rupture rate goes up to 40%. Okay, so the complication rate of your intervention increases. And this is what a rupture looks like. So that's the aneurysm, that out bulge that I talked about in the blood vessel, and that's what's happened. So it's swollen up and it's ruptured. So that's swollen up, it's ruptured, and this is just contrast, i.e. blood, which is just outside into this tumour. We're getting better and better at this. Scans are getting much more accurate. We're able to pick up much smaller lesions. The technology as far as probes are concerned and the materials is getting much better, as is the expertise. So this is from last year. So this is what we can see, and this is what's called digital subtraction angiography, where you just get much better pictures. So a catheter's been placed in the groin, it's gone up the artery, the aorta, and that's gone into the left renal artery, and you just get this beautiful arterial tree. And you can see this is an all normal kidney, and then you're starting to see some abnormal vessels. Okay, and then what you can here we go, the catheter's gone down further. And then what you can do is you can go bring it right down into there and block off these little bits. This is stuff we couldn't do 5 years ago. We certainly couldn't do it when all those papers were published. It's another picture, really nice picture coming in. And there's the AML. It is point, yep, you can see it. There's the AML, and you can see it really you can just see the vasculature is completely different. This is normal vasculature, like a tree. And here it's just odd little dots. Those are all little aneurysms, these little dots that you can see. Does it come out? Does it project well? Good, yeah. So these little dots, those are all little microaneurysms. And those are the bleeding points, or those are the potential future bleeding points. And so in this case, it's sort of fed by this one or two little vessels that go from normal kidney to this AML, and the plan would be to try to block it off here. They don't often shrink. They can shrink, but they don't often shrink. That's because the majority of them are made up of fat, not the blood vessels, and it's only the blood vessels that you're treating. And here's one which is completely, so this is the kidney outline. And here we go on. We've done the same thing again. Aorta, right side into the renal artery, gone right into these what's called segmental vessels. And here, you can start to see the abnormal vasculature within it. It's almost like a star there, a stellate star. And that could all be blocked off. This is the draining of the kidney. So this is where the urine, so we're putting contrast into the blood vessels, and it's going through the blood vessels into the kidney, and it's doing what a kidney should do because it filters this contrast medium, and then it's going into here, and that's will go down onto way down there into the bladder, and then it'll be weed out. So as I said, it's really been a great advance as far as the equipment's concerned, and therefore we can absolutely target the tumor rather than losing a lot of the kidney. It's not without its complications. So this is acutely, this is doing a scan immediately afterwards, and what you can see is this fresh white coloration is blood. Okay, so there's been a bleed immediately after. But this is 6 months later, and this was this was the AML, all of that. That's the bit that's not bled into, and that's the bit that has bled into. But 6 months later, it's all shrunk down, and you can see. So this is skin. This is what's called. This is the fat under the skin, subcutaneous tissue. So that's fat. That's what fat looks like on a CT scan. And it's not dissimilar to here, okay, because that's fat as well. So they look very similar. So this is what an AML looks like. You can see the characteristic has changed. Doesn't look that is different to that. So the character, not only has it shrunk, but in this particular case, the character of it has shrunk. That's what a normal kidney looks like on the other side. So, what about follow-up? So if we intervene, if we operate, or if we embolize, what should we do follow-up-wise? Well, there are no guidelines. Okay, so we have to really, as clinicians, we have to make up some sensible guidelines. And first important note is size may not be the best indicator. I've tried to allude to that with the fact that most of an AML is fat, and the fat bit is not the bit generally that's causing bother. It's the blood vessel, which is probably the smallest bit of it. And so the fact that it's a 10 centimeter AML doesn't necessarily mean that that's the problem bit. It's the blood vessel bit. So here we go, the vascular bit of it. So it might be that, it's the vascular bit of it by doing an angiogram, is that's what we want to find out. What about fat-rich AMLs? i.e. ones that are predominantly fat and very little blood supply. Well, no amount of embolization is going to do a job to that, and so surgery might be the best way forward to remove it once and for all. So what I've spoken about, lots of scans are going to be required after intervention. Now, is that going to be at your local hospital? Will it be at Nottingham, where you come regularly? Will it be at the QE? In an ideal world, it would be at the QE, because, it's where we work, it's where we can ask for the exact scan that we want. But we realise that this is not an ideal world, and it involves quite often an arduous and horrible trip. And so we've negotiated that maybe we should have it done with Simon here in Nottingham. But we're more than happy to sort of cut our cloth to fit, whatever you want. So this is what we agreed in our last meeting, that after any intervention, it should be a CT scan. Sorry, we should have a CT scan before any intervention to work out the actual anatomy of the lesion, to work out the blood supply of the lesion, to work out how I will tackle it, or Ian will tackle it radiologically, and an ultrasound scan if it's cystic. And then after an embolization, probably a yearly MRI scan. CT's got radiation exposure risks to it. And if you're going to do frequent scans, you're probably better off doing MRI scans. MRIs show lovely anatomy, but they're more difficult to read, a lot more time consuming to read. So yearly MRI scans is essentially what we're saying. So who would we like to see in Birmingham? Those ladies with TSC, LAM, who've got AMLs of more than 2 centimetres, because we know they're at a higher risk of rupture. Sporadic LAM AMLs more than 4 centimetres. Having said that, there are certain caveats. So if there's only one kidney, I've already shown you there's a lot of evidence that treating it when it's small is probably better than waiting for it to get bigger, because really the intervention when it's too big is loss of that kidney. If it's multiple and bilateral, very similar reasoning, you're at risk of losing kidney function. Those that are symptomatic, and those that are so big that they're starting to cause problems with the kidney. Pregnancy is an interesting one. We know that cancer tumours and also AMLs are at risk, a potential risk of bleeding and rupturing in pregnancy, because of all well, we don't really know why, but it's presumed because of all the physiological changes. And so, that's a really important question. There's not much literature on this whatsoever. But it's a pretty big risk. Well, we don't know. It's difficult to quantify it, really. So this is something that we need to, to really find out a bit more about. I don't think we can skip that one. I don't want to put too much into this. There's that recent Lancet article, but there are certainly a number of medications out there, new medications out there. Sorry, I'll take a step back. Old medications where a new indication has been found to use them. So rapamycin, that's been around for years and years. That's been around to treat organ rejection in transplant surgery for decades now. And what this trial showed was that giving rapamycin, this is each individual patient, what happens to the AML? Well, they get smaller. Oops, sorry. They get smaller, but then when you stop the treatment, they get bigger again. And again, same here. So they get smaller on treatment, but the problem is it increases, that they increase in size when you come off treatment. Now, the problem with these trials is that, yeah, there's no doubt that the AML gets smaller, but they weren't powered to answer. The problem with AML at that kind of size isn't its size, it's the bleed risk. And there's just no data on that in the studies about whether being put on this tablet, which has got its side effects and is not cheap, actually decreases the risk of bleeding. That is the bottom line for an AML. So what about future? Well, there's a lot we know, but there's a lot we don't know. And by concentrating minds and concentrating experience, we're hoping with time, we might be able to start answering some of these gaps in our knowledge. How best to treat? How often to treat? How to follow up? You know, all of these things we don't know, and hopefully we'll be able to answer that more with data rather than just intuition. And we know that just with radiology, surgical technique has improved massively as well. So with small tumours, they're now often done at the QE, small cancers often done at the QE with keyhole surgery. Now, I don't think we're there yet with angiomyolipomas because of the bleeding risk, but why, you know, it won't be, it'll be a matter of time before we do get there. What about using both? An embolization to block off the feeding blood vessel into it to make surgery a little bit easier and requiring less blood transfusion afterwards. What about robotics? You know, it's all coming on, and you know, I can't see any reason why this can't be applied here. I think that's all I want to say. Thank you very much for listening.